Please note, the opinions expressed in this podcast are those of the individual speakers and do not necessarily reflect the views of Tri-County Orthopedics. Any medical advice or treatment recommendations discussed should always be reviewed with your own healthcare provider. This podcast is not a substitute for professional medical advice, diagnosis, or treatment.
Welcome back to the OrthoZone Podcast by Tri-County Orthopedics. Today we have our newest doctor with us for a two-part episode series where we're going to be talking all things elbow. So welcome, Dr. DiPrinzio. Before we get into that, I just want to tell our listeners a little bit about yourself, where you did your training, medical school, residency, fellowship, and then how did you end up here at Tri-County?
Sure. So I'm a New Jersey native. I grew up in southern New Jersey, and then I went to my undergrad and medical school at Rutgers in New Brunswick. I did my residency at Mount Sinai in New York City, and then additional training in hand, wrist, elbow, shoulder surgery at Duke University in North Carolina. And I was in practice in New Jersey for about 4 years prior to joining Tri-County Orthopedics, but it's been really great so far, and Tri-County is a great practice, so I'm happy to be here.
So for today, we are going to be breaking down elbow basics and also talking about fractures. And then in the next episode, we will talk more about sports injuries and arthritis of the elbow. So to start off for our listeners, to get into the basics, do you want to just describe a little bit about elbow anatomy?
Sure. So when I talk about the anatomy of the elbow, very basics. When I talk about the front of the elbow, I'm really talking about where the elbow bends or the crook of the elbow. And when I talk about the back of the elbow, that's where when you put your elbow on an armrest, that's the point that's going to be hitting the armrest. The side that's closer to your body or the inner side, we call that the medial or the ulnar side. And then the outside of the elbow, further away from your body, we typically call the lateral or the radial side. When it comes to the bones of the elbow, there's mainly the upper arm bone, which is called the humerus. So that makes up the top of the elbow joint. And then there's the two forearm bones, the radius and the ulna, which make up the bottom of the elbow joint. And at the elbow, the main bony connection is between the ulna and the humerus that makes a hinge. So that lets your elbow kind of bend up or flex or straighten out and extend. And then the radius at the elbow is almost circular shaped. So it still allows for flexion and extension, but it's also why you can leave your elbow at your side and put your hand palm up and then, put your hand palm down. So that rotation of the radius allows you to do that. So just from the bones, I think you can tell that this is a fairly complex joint. It allows for a few different types of motion. In terms of the ligaments around the elbow, just like the knee, you have a collateral ligament on either side. So the medial or ulnar collateral ligament and the lateral collateral ligament. And then lastly, there's the muscular attachments about the elbow. So the main ones that most people think of are the biceps, which flexes your elbow up. That's going to be in the front of your elbow. And the triceps, which extends your elbow. So that's going to be in the back of your elbow. And then the other thing is all of the muscles that bend, flex, and extend your wrist, move your fingers back and forth, they pretty much also start around the elbow. So there's a lot of muscular attachments for just not only elbow movement, but also wrist and finger movement.
So obviously the elbow is a complex part of the arm. How often are you seeing patients coming in with problems related to their elbow in your own practice?
I think elbow injuries and pain is actually fairly common. In my practice, I do hand, wrist, elbow, shoulder all the time, so I probably see this a little bit more frequently than maybe a general orthopedist. But when you include all of the issues that can go on with an elbow, which are regular wear and tear and repetitive motion, fractures, sports injuries, and even elbow arthritis, there's a lot of different problems that people can have. So in my practice, it probably makes about maybe 25 to 50% of the patients I see. Not everybody needs surgery, but I do find it interesting, and I do think that patients tend to do well as long as you come up with a good treatment plan for them.
All right, so now we're going to get into fractures around the elbow. So if you want to just start off telling us a little bit about the different types.
Sure. So in general, when people have a fracture around the elbow, whether they need surgery or not, they'll typically have a little bit of stiffness. And I just say the elbow is an honorary joint. So whenever it gets hurt, fracture, even bruise, there's going to be some stiffness that comes along with that. So no matter how we end up treating elbow injuries, that's part of the treatment plan, is the rehab afterwards. In terms of what breaks are common, the most common fracture is actually a radial head fracture. So as we discussed before, the radius at the elbow is almost like a little circle, or what I call a golf tee. And since it's a smaller bone, a lot of the times the regular force, even from a ground level fall, will be able to create a small fracture at the radius. The good thing about radial head fractures or radial neck fractures is that the vast majority of them don't need surgery. There's not a significant amount of displacement, and they typically heal reliably well. The biggest risk, as we had touched on, is actually stiffness. So many times when someone has a radial head fracture that doesn't need surgery, I'll counsel the patient that yes, this is going to be sore for maybe 1 or 2 weeks. We'll probably start with a sling, maybe an ACE wrap, and then we'll actually progress to formal therapy rather quickly, even in the first few weeks, to try to help the elbow get back to its regular range of motion, help the patient get back to their regular life.
So most of the time you're not operating on?
I would say most radial head fractures that I see do not need to be operated on.
Okay. And then if they do, what does that entail?
If you have to operate on a radial head fracture, it's usually because it's either a very large piece that was broken and displaced, or it was a fracture in combination with other fractures around the elbow, which I'll touch on in a little bit. If we're talking about an isolated radial head fracture, it's typically an incision around the elbow, and I'm either fixing that with screws, or sometimes we actually replace the whole radial head, which sounds like a big surgery, but in reality, the radial head replacements do quite well. They're very durable, and patients tend to have a good clinical outcome as well.
All right, so the next fracture?
So another common fracture that we see around the elbow is something called an Olecranon fracture. So what the Olecranon is, I consider that the elbow tip. So again, if you were to rest your elbow on the arm of your chair, the first point or the tip of your elbow that's going to touch the chair is the Olecranon. That's actually part of the ulna, so that's part of the hinge that goes around the elbow. Also importantly, that's where the triceps tendon attaches to. So every time you straighten your elbow, the triceps tendon is pulling on the Olecranon and helping your arm do that. Most of these Olecranon fractures come from direct trauma, so someone that fell directly onto their elbow. The tough thing about Olecranon fractures is that unlike a radial head, once the Olecranon displaces, the triceps tendon will keep pulling on it, so it will kind of prevent this from healing well. So especially in a young active population, many of these Olecranon fractures need to be fixed. That means making an incision, using a number of different implants that we use for this, and making sure that those bony pieces heal well to each other. The good thing about Olecranon fractures is that even though elbows have a tendency to get stiff, I find that these patients are able to work through that stiffness rather quickly and don't have many long-term deficits when it comes to recovery after fixation.
And for both of these fractures that we've gone over so far, are those being diagnosed with X-ray?
The vast majority of the time, these fractures are being diagnosed with X-ray. If it's a very complex injury or I don't feel like I'm able to see appropriately, I might opt for something like a CAT scan, but for radial head fractures and Olecranon fractures, the vast majority of these only need X-ray.
Okay. For the Olecranon fractures, what is the healing time looking like for the patient?
So as we talked about, many of these end up going on to surgery. So after surgery, I'll typically keep the patient in a splint or a cast for about 2 weeks just to let the skin heal and to let fracture healing start. And we actually like to start range of motion rather early. So I'll start people in formal physical therapy even at 2 weeks just to start some range of motion. In general, fractures heal in about 6 to 8 weeks. And if we're talking about very vigorous activity such as sports, weightlifting, or a heavy manual labor job, we're usually looking at more like 3 months.
All right, so next is the distal humerus fracture.
Yes, so distal humerus fractures tend to happen in 2 groups of people. So in young patients, it's typically a high energy injury. A lot of the times I'll see this during winter when we have skiing and snowboarding season. And then in an older population, it's typically going to be ground level falls, trips down the stairs. Any trauma that results in someone falling onto their elbow can result in a distal humerus fracture. Again, the humerus is the upper arm bone at the joint. So in fractures of the distal humerus, typically the forearm bones are preserved. Often distal humerus fractures require surgery because they actually involve the joint surface of the elbow. And whenever that happens, you have to restore the joint surface, realign those fracture fragments to make sure that in the long run, the patient will have a functional elbow. Distal humerus fractures typically require a longer surgery, maybe a longer recovery. I would say that elbow stiffness stiffness is very common, and always some stiffness is to be expected. In an older population, when it comes to these fractures, sometimes we talk about actually doing an elbow replacement. I think that was very popular maybe 5 to 10 years ago, and while it still holds an important role in managing these fractures, I think many times we're opting towards either treating these with fixation, just as in the younger population, or sometimes we even treat these non-operatively. And the reason being is that the complication rate from an elbow replacement can be rather high. So if it's the right treatment for you, yes, that's how we will manage this. We would certainly consider other options as well.
Is it more common in the older population?
I would say in general, when I'm thinking about distal humerus fractures, yes, probably I will see this more in an older population. Now, that being said, most of the time I'm seeing these patients that are coming into my office. So the very high energy traumas, such as car accidents, they're probably going to be going straight to the hospital and have a distal humerus fracture in combination with other injuries. But in general, when someone's coming into my office, probably going to be the older population.
Okay. And then out of the 3 fractures we just talked about, what is the most common one that you see?
I would still say that the radial head fracture is the most common. And again, fortunately, many of these don't require surgery. The Olecranon fracture and the distal humerus fracture may be somewhat similar in presentation. And as we talked about, unfortunately, many of those need surgery just to make sure that the patient has a good outcome.
All right. So the last thing we're going to talk about is the terrible triad injury. You want to get into that a little bit?
Sure. So the name kind of says it all for this. These are somewhat gruesome injuries about the elbow. The reason they call it a terrible triad is because it's actually a combination of a few different problems. So typically this is going to be an elbow dislocation, and then there's going to be fractures of the radius and the ulna. So kind of what we had touched on in the beginning of our talk today. So what makes these so complex is that not only is there fractures of the bone, but there's almost always injuries to the ligaments around the elbow as well. So if we go back to the beginning of our talk where we talked about collateral ligaments and the soft tissue stabilizers, this is really a combined injury of bone and soft tissue. In terms of radial head fractures, although many isolated radial head fractures don't need to be fixed, when it comes in combination of a bad injury like a terrible triad, we do end up having to address the radial head many times. And like we talked about earlier, this may require fixing the radial head with something like screws, or it may require a radial head replacement. Again, when we're talking about radial head replacements, this is different than a replacement of the entire elbow joint. The radial head implants are very stable and durable, as opposed to the elbow replacement, which has a higher complication rate. The other types of fractures, so the fracture of the ulna is typically a piece of the ulna called the coronoid. I almost describe this as the opposite of the olecranon. So the olecranon is the tip in the back of your elbow. The coronoid is the tip in the front of your elbow. You can't feel it because it's so deep under the soft tissue, but it's still very important for stabilizing the elbow joint. And then lastly, in a terrible triad injury, there's almost always an injury to the lateral collateral ligament. So typically when the elbow is dislocated, some ligament injury is typically for the elbow to dislocate, there's going to be some ligamentous injury, and most commonly that's the lateral collateral ligament. Most of these injuries end up needing to have surgery just because there's so much damage done to the elbow joint. In terms of the bones, we either fix them or repair the soft tissues around them to stabilize them again. And in terms of the ligament, it's typically fixing that ligament. Stiffness is very common after terrible triad injuries, but I always tell patients I would rather your elbow be a little bit stiff than the elbow continue to dislocate even after I do my surgery. So a little bit of stiffness early on I think is totally fine for these, just to make sure that the elbow remains stable, and we'll always work out that stiffness later on.
I know you said there's a lot of stiffness after the surgery. What is the recovery usually like?
So I treat terrible triad injuries very similar to how we would treat any other fracture around the elbow. A short period of immobilization, usually about 2 weeks, followed by guided range of motion with physical therapy or occupational therapy. I usually would consider continued bracing, at least intermittently, sometimes even with a hinged elbow brace, which is a brace that stabilizes the elbow while still allowing for some motion. Just like we said, the elbow is an ornery joint. It likes to get stiff. As long as you are safely performing range of motion, I think that goes a long way in terms of having a good recovery.
All right. Well, I want to thank Dr. DiPrinzio for coming on today. This is the part 1 to our little series about elbows. So next one, like we said, will be arthritis and sports injuries. So thank you for coming on.
Thanks so much for having me.
If you enjoyed today's episode, be sure to subscribe so you never miss an update. Don't forget to share the podcast with others who might find it helpful, and follow us on Facebook and Instagram at Tri-County Orthopedic. orthopedics to stay connected. Thanks again for tuning in, and we'll catch you next time.